Assalamu alaikum. I'm Dr. Matiullah. So in the first part of our talk, we were discussing about the diagnosis of diabetes mellitus, the types and classification of diabetes mellitus. Then we touched upon the mechanism of action of type 2 diabetes and the treatment. So today we will be discussing about the details of treatment. So the major pathophysiologically based therapies for type 2 diabetes are the following. So initially we were thinking that type 2 diabetes may be just the insulin resistance, and with the passage of time there is some insulin deficiency. But now we know about this ominous octet, the several mechanisms of action of type 2 diabetes, and we know the therapies targeting all these mechanism of actions. So at the level of pancreas, there is pancreatic insulin secretion is decreased and the glucagon secretion is increased, and that glucagon secretion leads to insulin resistance. At the level of gut, there is decrease in the incretin effect. The GLP of the body is decreased, the glucagon-like peptide is decreased. And there is also carbohydrate delivery and absorption of glucose is increased in diabetic patient. At the level of liver, there is increased hepatic glucose production. And at the level of kidney, there is decreased glucose excretion from the system. And there is peripheral glucose uptake is decreased in a diabetic patient. Now, the drugs target all these sites. At the level of pancreas, the insulin and sulfonylureas will result in increased production of insulin. The GLP will also promote the increased insulin production, glucose dependent one, and they will decrease the glucagon secretion. At the level of the gut, incretin effect is enhanced by glucagon-like peptide receptor agonist, GLP-1 receptor agonist, and DPP-4 inhibitors. At the level of liver, the metformin acts by decreasing the glucose production, the gluconeogenesis is decreased, and the insulin resistance is also decreased. At the kidneys, there is action of SGLT2 inhibitors, the sodium glucose transport inhibitors, that will result in increased excretion of glucose from the kidneys. And thiazolidinediones and metformin also act on the muscles and increase the peripheral uptake of glucose. So basically we have the insulin providers, the insulin and sulfonylureases, the GLP-1 receptor agonists and the DPP-4 inhibitors. Both of them are insulin incretin enhancers. The body incretin effect is basically when we take glucose by orally, there is a larger amount of insulin produced as compared to when we inject glucose IV. This is because of the GLP hormone, the glucagon-like peptide, the incretin effect. This is lost in diabetic patient, and in a GLP agonist form, we can provide that, and in the DPP-4 inhibitor form, we can actually indirectly increase the body's own GLP, which is decreased in the diabetic patient. Insulin sensitizers are metformin and thiazolidinediones. And then we have the glucose excretor, which is the SGLT2 inhibitors. These are grouped together over here. The first one is insulin. Obviously, there are many types of insulin. There will be one lecture on the details of insulin. So there's just the long acting, the intermediate, and the short acting. Obviously, there is no limit to the A1C, and the side effect is, the major side effect is hypoglycemia and weight gain. Sulfonylureases were the older ones, are no more used that much. And even the Dianyl, which is the glabenclamide or glyburide, is also not that much used. We use two of them. One is the gliclazide and the other is glimepiride. So glimepiride comes in 4 doses, 1 mg, 2 mg, 3 mg, and 4 mg. It is used once daily before breakfast. And gliclazide MR comes in 30 mg and 60 mg, which is the diamacron MR 30 and 60 mg. And glimepiride is by the name of Emeril and Gatril. If you compare both of them will cause hypoglycemia, and the A1C reduction is also 1 to 1.5%. They are effective, and they may result in weight gain. But when you compare gliclazide with glimepiride, there are several trials that compare both of them. The HbA1c lowering is same in both of them, but hypoglycemia in gliclazide is lower as compared to glimepiride. So I would prefer gliclazide MR, that is the diamacron MR, as compared to glimepiride. Then we have the metformin that comes in Nudipar or glucophage. You can start from 500 mg twice daily, and then go on to 850 mg, and then 1000 mg BID twice daily. The XR form is also available, and then we have certain metformin which are in combination with sitagliptin, like Sitamet or Trivamet or Tegipmet, all these drugs. Then the metformin is basically very effective, 1 to 1.5%, and the GI side effect is there. But if you start slow and go up slow, titrate slowly, then it will be less. The GI side effects will be less. There is association between metformin and lactic acidosis in patients who are renal deficient. Otherwise, if the creatinine is normal, the GFR is above 30, it will not result in lactic acidosis. Avoid in all inpatient admission patients who are sick, who has sepsis, metformin, because it will result in metabolic acidosis. Thiazolidine the pioglitazone, has many side effects, like, for example, fluid retention, weight gain, osteoporosis, or bone fractures. And there's also questionable association with bladder CA, and we avoid in heart failure patient or prone to heart failure patients. So it's a double-edged sword to use pioglitazone. On the other hand, it has good efficacy, 1 to 1.5% HbA1c. There is no hypoglycemia, and it has good results in those with insulin resistance and fatty liver. But it should be used by specialists, because there are a lot of side effects that should be considered before prescribing pioglitazone. The lower dose is preferable, the 15 mg dose once daily. Then we have the DPP4 inhibitor. The two DPP4 inhibitors, rather three, are available. Sitagliptin is widely available. Dose is usually 100 mg. And in someone who has a GFR of 45 to 30, we use 50 mg once daily. And if it is less than 30, then we use 25 mg once daily. Linagliptin 5 mg is used, and there is no need of dose adjustment in someone who has chronic kidney disease. So preferable in those patients. Both of them are neutral drugs. That means that there is no cardiac issues associated with that, and it also does not have any extra benefit in cardiac patients. But saxagliptin is one of the DPP4 inhibitors that should be avoided in heart failure. The side effects are generally, DPP4 is a safe drug. Efficacy is also lower than the other drugs. 0.5% is the usual efficacy, and there is no hypoglycemia usually associated with DPP4 inhibitors. Rather, there are no big side effects of DPP4, except that it should not be used in someone who had a history of pancreatitis. GLP-1 receptor agonist is an expensive addition to the drugs. It is currently available in Pakistan. Available are the semaglutide once weekly injection, dulaglutide once weekly injection, and the liraglutide once daily injections. Semaglutide by the name of Ozempic, dulaglutide by the name of Trulicity, and liraglutide is by the name of Victoza. So they're available widely in Pakistan. Price is around 16 to 18,000 per month. So you should know that when to write it, because it has certain benefits like weight loss benefit, cardiac benefits, renal benefits, blood sugar benefits, but it is very expensive and it is injectable, so patients may not prefer it. The GI side effect is the most common side effect, but if you start with low dose and then go slowly, there will be lesser side effects. And someone who has pancreatitis history should be avoided. Then we have the SGLT2 inhibitor, the canagliflozin, dapagliflozin, and empagliflozin, and also ertugliflozin. The two preferable one are obviously the empagliflozin and dapagliflozin, available in Pakistan. They usually cause polyuria, and also patient will be prone to UTI and genitourinary infections. So patient who has previous history of UTI, recurrent UTI, genital infection, it should be avoided. In someone who has blood sugars of 300s and 400s HbA1c of more than 10%, it should be avoided, because there will be a lot of blood glucose going into the urine that will result in polyuria, polydipsia, and dehydration, and it also will prone the patient to UTI. So the patient initially should be managed with other drugs, blood sugar should be maintained, and then started SGLT2 inhibitor in someone who has Number one, obese, who is obese, who has cardiac disease, heart failure especially, and who has nephropathy, incipient nephropathy, in which the GFR is above 45, but there is albuminuria. It will be preferable in all those patients. It should be avoided in someone who is thin, lean, or who has type 1 diabetes, because it will result in euglycemic decay. So the studies of canagliflozin associated with the osteoporosis and bone fracture as well. So this was the FDA mandated in 2008 that all new drugs will show the CV safety, cardiovascular safety, because before that we know that there was this drug rosiglitazone that resulted in increased cardiac side effects, increased MI. So then this was mandated for all the drugs by the FDA that now they should show a cardiovascular outcome trial. So then we had a lot of new drugs, and all of them had the cardiovascular outcome trials. I don't want to go into the details, but just remember that the three most important groups, the DPP-4 inhibitor, the GLP-1 receptor agonist, and SGLT2 inhibitors, all of them have their own cardiovascular outcome trials. In all these, the simple thing to remember is the DPP-4 inhibitor trials were all neutral, neither causing any cardiac side effect or extra benefit, except the saxagliptin, which had a minor increase in heart failure. So it is avoided in heart failure. But the TCOS trial, which is the sitagliptin, there was no increased heart failure or increased MIs, but there was also no decreased MIs in someone taking sitagliptin. Then we had the linagliptin, the Carolina and Carmelina trial, again, neutral trials. And then when talking about the SGLT2 and GLP-1, there were remarkable trials, and that actually changed all the scenario of management, and the guidelines were changed accordingly. So in the GLP-1 receptor agonist leader trial for the liraglutide showed increased benefit in cardiac patients. And in the semaglutide, the SUSTAIN 6 trial again showed cardiac benefits. Dulaglutide also showed some cardiac benefits. The SGLT2 inhibitors, the empagliflozin, EMPAREG trial, and dapagliflozin declared to me, again showed cardiac benefits, especially in the heart failure group, and also the renal benefits, the nephropathy benefits. Then we had specialized special trials like DAPA heart failure trial, Emperor reduced trial, Emperor preserved trial for the empagliflozin and heart failure. So all of these trials showed benefits in heart failure cardiac patients, and also the DAPA CKD trial showed improvement in kidney disease. So here are these trials, just to remind you all: the DPP-4 inhibitor, the TCOS trial, sitagliptin, which comes in TAGEP, Trivia, Inosita, Sita, Januvia, all these, the neutral trials, Carmelina, linagliptin neutral trial. It's now available in Pakistan as well. Saver-Timi trial, saxagliptin, showed more heart failure hospitalizations. SGLT2 inhibitor, empagliflozin trial basically showed beneficial cardiovascular and less heart failure hospitalization. Canvas trial, canagliflozin, is not available in Pakistan. There will again less hospitalization for heart failure and benefit for nephropathy. Declare-Timi, dapagliflozin, less heart failure hospitalization and benefit for nephropathy. The GLP-1 receptor agonist, the leader trial, liraglutide, had beneficial cardiovascular benefits, and SUSTAIN 6 again had cardiovascular benefits. So I don't want to go into the details of each trial, but remember one thing, that now there is a paradigm shift, that from glucocentric approach, we are more towards the approach in which we have to see the patient and the comorbids and then decide about the drugs. And there's this study which basically showed that instead of starting the drug, single drug, and then adding one after 3 to 4 months, and then again another, this will result in someone who has long-term uncontrolled blood sugar. Rather, you should target the blood sugars initially and control it with dual agent, and that will be sustained for long-term, and it will have metabolic memory. So as per the American Diabetes Association guidelines, so metformin is the preferred pharmacological agent of choice. This is the first line treatment. This should be started in all type 2 diabetes patients at the outset of diagnosis. And then we should also understand that there are certain side effects and precautions and contraindications that should be remembered. And then we should add other drugs, including insulin, and metformin should be continued as far as there are no side effects or any contraindications to that. early combination treatment is preferable, as just we showed. And someone who has weight loss, polyuria, polydipsia, blood sugars of 300s and 400s, A1C of 10-11%, insulin glargine should be at least added to the regime. Okay, so a patient-centered approach should be basically used, and that patient-centered approach should guide the pharmacological agents. And based on the comorbidities, the renal, the cardiovascular comorbidities, the efficacy, hypoglycemic risk, and impact of weight, and the cost and risk of side effects, all of these should be kept in mind and then decided the therapy. So in patients with type 2 diabetes, GLP-1 receptor is preferred to insulin when possible. And again, we should understand that there is the price issue in this. And also we should again check the patient after 3 to 6 months. So this is the ADA algorithm. As you can see, that first line therapy is metformin. Then based on the indicators of high risk for established cardiovascular, indicators of high risk or established atherosclerotic cardiovascular disease, CKD, or heart failure, in that group, we should consider either GLP-1 receptor or SGLT2 inhibitors. And if there is no such comorbid cardiac or renal comorbid, then we should straight away go to this flow diagram. So we should discuss this in detail. So the first group is atherosclerotic cardiovascular disease, someone who has stroke, MI, or peripheral arterial disease, or there is increased high risk of that. For example, the patient is smoker, has dyslipidemia, hypertension, family history of ischemic heart disease. So in those patients, GLP-1 with proven CV benefit like liraglutide, semaglutide, dulaglutide should be considered, or SGLT2 inhibitors, especially empagliflozin, should be considered in them. And if the patient has heart failure, then obviously SGLT2 inhibitor has superiority over it, and both dapagliflozin and empagliflozin are preferred in those patients. Now, if the patient has CKD, now again, this is CKD, this should be understood and defined, that someone who has 2 or more persistent creatinine that are basically over a period of 3 to 6 months. Only single reading of 2 creatinine is not CKD, that is acute kidney injury. And in acute kidney injury, we know that all the drugs are avoided, because that will have side effects, and a lot of drugs will have problems in that. So the patient should have a CKD, and the creatinine should not be that much high. So here they want to say that basically the patient has nephropathy, incipient nephropathy, albuminuria. In those patients, whether microalbuminuria or even more preferable, macroalbuminuria, these drugs, the SGLT2 inhibitors, are very good. But if the patient has a GFR below 45, then they may be started, they may be continued, but the blood sugar will not be that much improved with it. Rather, they will just be slowing down the CKD of those patients. And in someone which is the patient, if the GFR is less than 45, we should not start empagliflozin or dapagliflozin, although some trials have even tried up till 30 GFR. But I think in practice, above 45 or even preferably above 60 GFR should be there if someone is starting SGLT2 inhibitors, because we never know if we start on SGLT2 and then that patient is lost to follow-up and may have worsening of kidney function and may come with other side effects. And simply these drugs won't work in someone who has a GFR less than 45, because they act on the kidneys and work. So our most important priority is blood sugars, and then the kidney and the heart benefits as well. So someone who has just albuminuria with a normal creatinine, they are the best drugs. SGLT2 inhibitors are the best drugs. And the second choice will be GLP-1 receptor agonist. So ASCVD, CKD, heart failure, these 2 groups. But if someone in whom we just want to lower the hypoglycemia side effect, there is no other comorbid, no cardiac or nephropathy, but we just want to lower the hypoglycemia, so we can use the DPP4, GLP, SGLT2 or TZDs. In someone who are obese, we should prefer GLP-1 receptor or SGLT2 inhibitors. Now, cost is a major issue, especially in our country, and in those patients, sulfonylureas and TZDs do work the best. And here you can see that in the guidelines, cost is the last, but for our patient, it may be the most important factor. So we have to understand what the patient actually wants. So that was all about the selection of drugs that we should be selecting for our patients, and then increasing the dose, and then adding another agent. And when the point comes, then we have also to initiate insulin and then titrate that. We will also talk about insulin in the next session. Thank you so much.